Today, at this time, we are going to have health assessment, and this is going to be our second lesson. We had the introductory part, and today we are going to talk about measurement of vital signs. So, in health assessment, we very well know that we need to take vitals of our patients, as having mentioned in the previous discussion. And therefore, today we want to look at vital observations. How do we measure our vital observations from our patients? So, our learning objectives for today, one is to define vital signs and explain why they are important indicators of health status of our patients. Then we need also to identify the normal ranges and variations of temperature, pulse, respiration, blood pressure, and oxygen saturations in adults. And we need to describe the equipment, procedures, and techniques for measuring vital signs accurately and safely. Then lastly, we need to recognize and report abnormal findings and document them appropriately. Because when these patients come to us, as we take these vital signs, we need to know what the cutoff measurements for each of it, so that we can be able to identify and understand whether our patient has gone to the abnormal measurements or they're still within the normal ranges. So we want to define what vital signs are before we get into our clear objectives, having mentioned the previous slide. So definition of the vital signs are objective clinical measurements that include temperature, pulse, respirations, blood pressure, oxygen saturation, and pain. So we provide just a snapshot of a patient's thermoregulatory and respiratory, and then also the cardiac status. So when you take these vital signs, it doesn't mean that exactly that's how the patient is, but just helps us to have that snapshot, just a clue of how our patients are doing, meaning looking at their temperature, looking at how they are breathing, that is the respirations, and also looking at the cardiovascular status or the cardiovascular system, and that one we can only get to know after taking the blood pressure and also their oxygen saturations. So according to the unit policy, they have their different ways of assessing vital signs. So when to assess vital signs depends on the unit policy. We have different units, we have different hospitals, we have different healthcare organizations, and each of them may have their own ways on how they are supposed to assess their vital signs. So according to the unit policy, it depends on how the institution or the health institution has decided to take their vital signs. So it's also upon admission of the patient. When we admit our patients, we also need to take their vital signs that can help us assess the condition of our patients. So when they report to the facility, the most important thing and the first things that we always take in health assessment of our clients is to do our vital signs before we admit our patients or during the process of admission. Then during status changes, when our patients change condition, the patient might have come and he has been very stable, but from nowhere you see the patient's condition is deteriorating. It's also very important that we take the vital signs that can help us to understand what could be happening in the different systems of the bodies or in the life of our patients. Then also before and after inversion procedures or treatments. After you've given the patient treatment, it's also very necessary for you to check the vital signs of this patient, and this can help us to understand any deviation due to the effects of the drugs that we might have used on our patients. I want to give an example for the case of high blood pressure. Before you give the drug to the patient, the antihypertensives, you are supposed to check the blood pressures. So when you measure the blood pressure of your patient and you realize that he needs to take antihypertensives, you also need to take after he has taken to see whether the effect of the drug is helping to reduce. Because sometimes you may give and still the measurement may still be very high, or it may go to below normal and you may need to intervene. Then before, during, and after blood transfusion, we also need to check the oxygen saturations of our patients, even the blood pressures, so that we can be able to understand whether our patients are responding to the management or they are not. Then also after surgery, especially post-operative period, we need also to continue monitoring the vitals of our patients, because you realize that after the surgery, our patients lose a lot of blood. So when they lose a lot of blood, there will be derangement in the vital signs, especially for the blood pressures and also the pulse. That will help us to understand what could be happening in the circulatory system, and we shall be able to intervene whether to transfuse our patients or not. So post-operatively or after surgery, it's very important to take the vital signs of our patients. It can be after every 15 minutes, and then after every 30 minutes, then we can take after 1 or 2 hours, and that is now when the patient is getting stable. Then before, after medications affecting vital signs, having mentioned clearly the effects of antihypertensives, and this can fall into the drugs of antihypertensives, or even the drugs that help us in the management of the cardiac system or the heart conditions. So we need to repeat the vital sign measurements in order for us to analyze or to understand or to know how our drugs are working in relation to the management of our clients. Before and after nursing interventions impacting vital signs. Also here we need to repeat the vital signs so that we can be able to assess whether interventions are actually improving the life of our clients. So here, this slide is trying to show us the different types of thermometers, and we very well know that a thermometer is used in taking the temperatures of our patients. So here are the different types of thermometers that can help us take the measurements of temperatures. So we have the digital, we have the one which has the mercury, and then we have these other ones that we have been using, especially the time when COVID came in. We're using them in order to assess the temperatures of our patients, and there we're able to know whether this person has high temperature and what does it mean, or this person has low temperature and what does it mean, and whether the temperatures are normal. So these are just basically the different types of the temperature, the thermometers, the equipment that we use for taking our temperatures, the way they are formed or the way they are made, but still they take and they do the same work. Temperature assessment, how do we assess the temperatures of our patients? So the normal temperature range is from 36.5 to 37.5 degrees Celsius. So you need to know the normal cutoff degrees of the temperatures so that you can be able to know the abnormal ranges and intervene accordingly. So the measurement sites, we need to know which sites we use for measuring the temperatures, depending on the age of the patients and also depending on the kind of patients that we handle. So we need to look at the sites, and here peripheral sites, the oral, and you should always give to use this kind of measurements in the age of 5 years to an adult. So you don't use below 5 years. Those who are below 5 years may not be able to use the oral thermometer. Then the axilla can be used in all ages, and this one is actually the most friendly type of site that we can use for all age groups to measure their temperatures. So this one starts from birth up to an adult, so it doesn't matter the age group that you are trying to check on their temperatures. Then tympanic, this one is from 2 years to an adult. So this one is also friendly in relation to the age because it starts from a lower age of 2 years to an adult. Then temporal artery. The temporal artery also is from 2 years to an adult. So you can identify where the temporal artery is and you can be able to check for the temperature, and that's why these thermometers are made in different designs in order to take temperatures in those different sites. Then the rectal, you can use it from birth to 2 years. So you don't use in adults the rectal thermometer. So we really need to know where we apply this kind of measurement sites, the age groups that we use them, so that we don't inconvenience and we don't actually insult some people in the way that we take our temperatures. Like you cannot come and start telling an adult who is very sound to give you to take measurements of temperature from the rectal site. Temperature assessment. How do we assess our temperature? So the core is invasive. So the arterial line, that is the radial or the femoral. So you really have to first identify where you're going to take your temperature from. You first assess, because it's very important for you to know how you're going to take your temperature, where you're going to take it from, and you need to put in some other considerations before you start taking your temperature. So temperature assessment is very core and is very important in a way that we need to know why we take, and that's why we said we need to know the ranges so that we can be able to identify the normal and the abnormal and intervene appropriately. So we need to look at the considerations. So we tend to have lower body temperatures, making increases less noticeable. So sometimes when some temperatures are very low, you may not understand what could be happening with the patient, and that's why we need to take them more frequently so that you can be able to understand and to know that somebody's temperatures are increasing. And like now, when you look at the patient who has come back from theater, the patient who might have lost a lot of blood, those patients need to be monitored frequently so that you can be able to see and understand either this patient is getting into shock because the temperatures are reducing, or this patient is developing infection and the temperatures are increasing slowly. By the time you get to know, if you're not taking these temperature assessments closely and frequently, you may get to know when the temperatures are above 40 and your patient is actually getting even into convulsions, because temperatures can lead to that. So normal body temperatures are typically 37 degrees Celsius orally. So when you're taking the oral temperatures, the most appropriate degrees is supposed to be 37 degrees Celsius if you're using the oral site. Peripheral temperature refers to extremities and the skin. So peripheral temperatures in relation to temperature taking, that means that you are going to take the temperatures from just the extremities and on the skin. So you don't put it in the orifices as in the mouth or in the rectum. So it talks about the extremities and the skin, that those are the peripheral temperatures. Then the core temperatures measures vital organ temperatures. So those are the ones that they call core temperature measurements. It looks at the vital organ temperatures, sites of measurement, and mean temperature range. So you need to know in the core that you're taking, what is the range, what is the normal measurement, what is the mean temperature range that you need to know so that you can be able to differentiate the normal from the abnormal. So in the relation of the core temperatures that you're going to take, looking at the vital organ temperatures, you're looking at the ranges of 36.5 to 37.5. Then for oral, you're going to look at 37.0, in brackets is 35.5 to 37.5. So those are the normal ranges. So there is no specific cutoff number or figure of the temperature, but it's always measured or considered in ranges. Then tympanic, this one is 35.5 to 38.0. That is in relation to tympanic temperature ranges. So the one that is considered more, or the median, is 36.5. For the rectal, that one we look at the range as being 36.6 to 38.0, but the mean of it all is 37.5 degrees Celsius. Then axillary being the most common one, are the temperatures that we look at considered most as the normal range is 34.7 to 37.3, depending on the altitude, depending on the weather and the climate where someone is. But we look at or we consider the minimum of 36.0 as our mean range or mean temperature for axillary sites. Then temporal artery, it's 35.0 Celsius. Typically, 37 degrees Celsius orally, that is what we look at. That is for normal body temperature if you're using oral site. Then peripheral temperature refers to extremities and the skin, having mentioned previously. And this slide actually has repeated what we have already explained, including this. So let's talk about temperature measurement considerations. What do we need to consider when we are taking or measuring our temperature? Accuracy. Accuracy considerations are very important, and temperatures can be affected in different ways. So we want to look at the different ways in which temperature measurements can be affected. So temperature measurements can be affected in relation to the site where you're going to take your temperature, and that's why we looked at the ranges in the previous slides. The different sites have different ranges. So the sites where you're going to take your temperature can also affect the temperatures. So we have to consider that. And then device type, the type of the device that you're going to use also can affect the temperature. So when you use the rectal thermometer and when you use the one of the oral, it doesn't mean that they may give you the same readings of the temperatures. So the device type is also taken into consideration on what you are going to use for taking these temperatures. Then the nurse's technique. The nurse's technique is also very key and vital in a way that how does the nurse put the thermometer? Because if you put the thermometer and the tip where the thermometer, the head of the thermometer is supposed to be placed either in the armpit, and you've not placed it, you've put it beyond and it has overlapped the armpit, then it is not going actually to take the right readings of your temperature. So you need also to consider the techniques on how you're going to place the thermometer. Then patience factors. Also the patience factors alone can affect our temperature. So we need to put this into consideration. Some patients might be so much emaciated, and when you put a thermometer on the armpit or at the axilla, it may not be able to hold, and therefore your readings may not be actually accurate. So we need to look at the patient's factors as we are doing our temperature measurements. Then the environment and the weather can also affect the temperature. So when you look at the weather, how is the weather? If it is cold, then you don't expect your patient to be having very high temperature. Then also if it is very hot, the temperatures may also increase, though the patient may not be very sick, or the temperatures are not high just because of the environment, the weather. So the environment and the weather contribute also to the deviations of the temperatures of our patients. So we have to look at that and put into consideration when we are doing our measurements. So we want to look at basically this type of the oral temperature measurement. What is it all about and how do we go about with it? So oral temperature measurement, you have to be consistent and reliable for core temperature. So when you're using it, you're going to put it inside the mouth, but it has to be consistent and reliable. Then it measures heat from sublingual blood vessels. So we have the sublingual blood vessels, and that is under the tongue. So the sublingual blood vessels can absorb so much because that place is actually so vascular, and in that way you're able to get the temperatures and when you read these temperatures, it may give you the measurements that may not be actually the same measurements with the patient that you had used the axilla kind of site. So measures the heat from the sublingual blood vessels. So as we talked about the site and also the technique, if you're going to take the oral temperature measurement, how are you going to place your thermometer? Because you're going to put it at the sublingual part of the mouth. So when you put it there, how is it going to be, and how are you going to place the tip of that thermometer so that it can be within those sublingual blood vessels, and that's when it can give you the right measurements. Then appropriate for conscious patients. This can also be appropriate for conscious patients because for them they are aware. So a patient who is not conscious, who is not aware, who is not mentally sound, you cannot use the oral temperature because it may end up chewing your thermometer. So appropriate for conscious patients, the ones that you can tell what you are doing and the ones can understand why you are doing it. So also caution with unconscious and confused, intubated, recovering from mouth or nose surgeries, very young, or those unable to follow directions. So this is a contraindication. So you don't use this oral temperature measurement for the patients who are unconscious, confused, the ones who are being intubated, the ones who are recovering from mouth or nose surgeries. So you don't use the oral site. Then also avoid hot or cold foods 30 minutes before measurement. So you have to look at this also critically because it can deviate or it can derange your measurements when you use the oral temperature and the patient has just eaten cold food or he has taken a hot tea within the 30 minutes. So when they finish to eat, just allow them rest a little bit for about 30 minutes, then you can take your oral temperature. Then interpret with caution after smoking or oxygen use. Also, this is very necessary to put into consideration because you may not get the normal ranges, having talked about them in the previous first slides. Let's look at the tympanic membrane temperature measurement. What are the advantages and what are the considerations? So what you need to consider during this type of measurement of temperature using this area, you need to immediately take up your readings. As you remove the thermometer, just take up the readings immediately because when you delay, you may end up not getting the right readings of your temperature. Then little discomfort. It also gives some discomfort to the patient because you're going to put the thermometer in the tympanic membrane and the patient will get discomforted. So you need to prepare this patient and this patient needs to understand what you're going to do, why you are doing it, so that the patient will be comfortable as you're carrying out your temperature measurement. Then detects the heat radiation from the tympanic membrane. So the heat radiations from the tympanic membrane can also increase these readings, and it may be the entire body temperature is within the normal range. So this can also be put into considerations depending on what readings that you have got from the measurement that you have taken. Then also convertible to an estimate of core body temperature. So you can also convert this to the core body temperature. So variability debated. So caution is critically ill, in critically ill or children. So you may not use it in the critically ill people or in children. So it is cautioned in using tympanic membrane temperature measurement in children and those who are critically ill. It's also affected by earwax, environmental temperatures, and improper technique. So if you don't know how to fix it, you may end up even injuring your patient's tympanic membrane. So it is cautioned on how you're going to do it, the technique on how you're going to insert it, and also the environmental temperatures can affect these measurements when you're using the tympanic membrane thermometer. and then also it can be affected by the earwax. Some people do not clean their ears, and when you insert it there, this can also affect the temperatures as you take these measurements. Then axillary temperature measurement is the most used type of uh, technique, or the most used type of measurement of temperatures. Most of our patients, whether young, whether newborns, whether old, whether unconscious, can be actually taken measurements using the axilla. So what are the characteristics being the most common one? So it's derived from the skin. So you take measurements from the skin. So when you put it at axilla, you are just putting on top of the skin of the axilla, somewhat protected from ambient air. So you just put in the axilla, and then you tell the patient to put back his hand and hold it firmly inside his axilla. Preferred for infants and young children, so it's all for ages that range from infants to young children to adults. So it doesn't segregate the age group, but for it works in all age groups. From the even the newborns, you can still use this axilla thermometer or temperature measurement. So consistently lower than core temperature, for it is lower than the core temperature, and it doesn't actually cause a lot of deviation unless maybe the technique of inserting is affected, but in most cases it's the most appropriate. It's also influenced by placement of the thermometer, which I've already mentioned. Then recent bathing, if the patient has just bathed, that helps to reduce the body temperatures. So when you put it on the skin of the armpit, then there you may look at the temperatures being low, and yet the patient actually not having low temperatures. The temperatures could be high, and just because he has just bathed, it has tried to reduce his temperature. So it is affected by the recent bathing of our patients. Then also vasoconstriction. Vasoconstriction can also affect the axillary temperature measurements. Then vasodilatation or vasodilation, not dilatation but vasodilation, and sweating also can contribute in the deviation of our temperatures using the axillary temperature measurement. So the temporal artery temperature measurement also is one of the ways in which we measure our temperatures, and that one is using the temporal artery, and that one was most commonly used the time when we had COVID-19. So what could be the characteristics? It is non-invasive, so you don't get into the body, but it's just on the surface of the body, and you don't even touch someone. You can just take it at a certain distance, but you're able to read the measurements or the temperature of your patient. And it's also inferred readings of temporal artery blood flow, so it helps even in that. Then temporal artery temperature measurement also is very important in a way that you don't get so much close to the patient. You can just take it at a distance when you're not touching the patient. So this one is also good in the prevention of infection transmission. So what could be the advantages? I've already talked about some of them. A superficial artery, because it is just at the superficial artery, that is the temporal artery, so it's just at the surface. So skin temperature is a fairly accurate measure of body temperature. So when you take the temporal artery temperature measurement, you may look at it and you may not understand, but actually this is one of the accurate measurements of our body temperatures. And I think that's why it was mostly used during the time of COVID, because we needed to get accurate kind of measurements to help us categorize our patients and also identify those who could have been having either COVID-19, so that they can be isolated for monitoring. So it arises from the carotid artery directly connected to the aorta. So this is just telling us how our temporal artery is connected, where it comes from and where it goes, where it is connected. So when you take the temperatures of the temporal artery, that means that you're getting them directly from the aorta, and that's all what is happening in all these major arteries. What you read from that temperature is also indicating what is happening in the carotid artery and what is happening in the aorta, being our major blood vessels. Not significantly affected by thermoregulation changes, high perfusion rate, and readily accessible. So this cannot be affected by the thermoregulation changes. And also hyperfusions don't affect the temporal artery temperature measurements. So our readings are readily accessible from any patient whom we come across, because you're not going to touch this patient, you're just going to position the tool or the equipment, and then you operate it, and in that you're able to see the results. It just shows you the readings, and when you see them, you can be able to interpret to say whether the temperatures are high or the temperatures are low. So it is readily accessible. Affected by diaphoresis and airflow across the face. So in case this patient is having airflow across his face, it can also affect, because this may give you low temperatures and yet actually the patient is very sick. So this can affect our temporal artery temperature measurements when there is airflow across the face of our patients during the time of taking their temperatures. Then often used in infants for its non-invasiveness. So before COVID came in, this was commonly used for the infants, and it's because you don't put them direct on the infants. And when you look at the infants or the newborns, they get scared when they are touched. They get scared when they put anything on them. So by taking taking their temperatures using the temporal artery temperature measurement tool was very convenient in a way that you don't interfere with them. Then avoid areas with scar tissue, open sores, or abrasions, because they will not give you the right temperatures. Then alternate site region behind and below the ear if the forehead is undesirable. So when you look at the forehead and you realize that you cannot take temperatures at that site, or it may not give you the accurate readings, then you can alternate to try to check behind the ear or also below the ear, and you may be able to get your readings. Accuracy and considerations for the rectal temperature measurement. So rectal temperature measurement is also one of the ways in which we take our temperatures, or in which we measure our temperatures in our patients. So what could be the accuracy and what are the considerations when you're taking temperatures rectally from our clients? One, thought to be the most accurate measure of core temperature. However, discomfort, embarrassment, and risk of perforating the rectal tissue. So it's always necessary for you to first get consent from our patients, and also the age group matters. People who are elderly or who are adults may feel embarrassed, and also it causes discomfort to these people. So the risk the rectal temperature measurement may also not be so convenient for the elderly people or for the adults when they come. And also for the case of the children, the newborns, it may cause also perforation of the rectal tissues as you're inserting it through the rectum. So it's also reserved for situations requiring high accuracy and when no other sites are available. So when you need high accuracy, then you can use this rectal temperature tool. And then also in case other sites are not available due to other conditions, or they are not able to use them due to maybe burns and maybe some infections on the skin, sores, then you can end up using the rectal site. So this is done basically in case you cannot use any other site, then that can be the only option that can be available for you to take the temperature of your patient. Also can stimulate the vagus nerve, leading to a slow heart rate and syncope. So this can also contribute in a negative way. In case it touches the vagus nerve, it can stimulate it, and the vagus nerve is connected to the heart actions, so it can affect the regulation or the functioning of the heart, and can lead to slowing of the heart rates and also the pulse. So we have to look at this very critically so that we don't end up having syncope, or we don't end up having a low heart rate. Then it's not used in young pediatric populations and specific patient conditions. So we don't use them in children because we may end up causing perforation, and also there are some specific patients whereby we may not use them due to their conditions. Then temperature regulation. How is the temperature regulated? So the hypothalamus regulates the temperatures, and the hypothalamus is part of the brain, and its role is basically to regulate the body temperatures. So it controls the body temperature through the thermoreceptors. So these are receptors in our bodies, and they're the ones that help in regulating the temperatures and with the control of the hypothalamus in our brains. So when we have a an impact, or when we have any injury in the hypothalamus, then it is going also to affect the thermoreceptors, and our temperatures in the bodies will be affected. So hypothalamus regulation is very important in a way that it helps in maintaining our normal body temperatures. Then heat loss and production. So when you look at the heat loss, our heat loss can be due to the capillary blood flow and sweating. So when we sweat and when there is increased blood flow in our bodies, then we can also lead to a loss of heat. And when we lose the heat, it can lower the body temperature. So that is the mechanism. Then heat production, there is increased metabolism, vasoconstriction, and shivering. So the body can regulate temperature by producing heat, and the way it produces heat is by increasing the metabolic rate in our bodies, and also increasing the vasoconstriction of our blood vessels and shivering, so that we can be able to generate heat. And when a person is feeling very cold, this is what happens, so that the body can produce heat and help our bodies to become warm. So temperature regulation, we have to look at the hypothalamus regulation, and that's what the hypothalamus regulation does. It controls body temperature through the thermal receptors. And when you look at the heat loss and the production of heat, we look at heat loss in relation to capillary blood flow and sweating, so that it can reduce the temperatures if we are feeling hot. And then if you are feeling cold, then we need to produce heat, and it is due to increased metabolism, vasoconstriction, and shivering. So what are the factors affecting regulation? So there are also some other factors that can affect heat regulation in our bodies. One of them is reduced muscle mass in older individuals. So for the case of the old people, when they become thin, when they have lost weight, also there will be increased loss of heat, and these people can be feeling cold because the mass in their bodies has reduced, and even the fat that helps to produce heat has reduced. So there'll be increased coldness among the older individuals. Then decreased ability to shiver in older people. So when you grow old, there'll be also decreased ability for you to cause shivering, and shivering helps us to generate heat, and in that reason the patient or the person ends up feeling very cold. Then sensitivity to environmental temperature fluctuations. We also need to be sensitive to the environment. So when we are sensitive to the environment, we can tell whether it is hot, and our bodies will be able to regulate the temperatures to normal. And it is by sweating, and then we shall lose the heat, and we get back to the normal temperatures. Then when the environment is also very cold, then we shall be able to cause shivering, vasoconstriction, and help to produce body heat to maintain warmth in our bodies. Then exercise temporarily increases body temperatures. So when we are feeling cold, we can also do some exercises that can help us generate heat, because there will be increased blood flow, there will be a production or increased metabolism, and in that way we shall be able to generate heat. Then the circadian rhythm variations. It's a 24-hour internal clock in our brain that regulates cycles of alertness and sleepiness of responding to light changes in our environment. So the circadian rhythm cycle, for it functions even when the person is sleeping, whether at night, whether at day. That's why you find that somebody is sleeping, but when there is a noise made somewhere, the person is able to wake up. When you come and you touch someone, he's able to realize somebody is touching me and yet he's sleeping. So these are all the actions or the functions of the circadian rhythm or the circadian cycle. So the circadian cycle looks at the functionality of the body or the brain basically for the entire 24 hours. So it works 24 hours internal clock inside our bodies. So that is what is called the circadian rhythm variations or the circadian cycle, which helps to regulate all the functioning of our bodies, keeps us alert. Even when we are sleeping, we are able to respond to anything that happens within our environment. You can go ahead and search about the circadian cycle. It's very, very interesting. And I think my first encounter was when I went to the university and I was in my second semester, first year, where we were studying about psychology and we were given an assignment in relation to the circadian cycle. And when I read it, it was very, very interesting. I didn't know that when someone is sleeping, it is the circadian cycle which is in action. So when someone touches you or when there is anything that makes noise or a sound within where you are or within your environment when you're sleeping, you can still wake up and respond. So let's look at the pulse assessment. Pulse basically refers to the effect of the heart's beating on the body's arteries. So when you touch the arteries, you find they are pulsating. That is because the heart is pumping blood through the blood vessels, and when they expand, that is now what we call the pulse. So it refers to the effect of the heart's beating on the body's arteries, as simple as that. So when you talk about the pulse wave, what happens during the pulse wave? The pressure wave produced throughout the arterial network during heart contraction. So when the heart contracts, that is what we call the pulse wave. When it contracts, just because there is that pressure that is produced throughout those arteries, then we can call it as a heart contraction, and that one leads to what we know as the pulse wave. So how do you regulate it? I mean the heart rate. So regulation of the heart rate. We all very well know and we have ever heard about the sinoatrial node, and that is SA as an abbreviation, sinoatrial node. This is the main pacemaker. It initiates the electrical impulses within the heart. So when we do not have a functional sinoatrial node, that means our hearts cannot function, cannot pump, because this is the center of the activity of the heart. So it's the main pacemaker which initiates all the electrical impulses in our heart so that the heart can function. So it's controlled by the autonomic nervous system. Autonomic means as something that is not controlled by anything. So it has its own autonomy to function. So it's controlled by the autonomic nervous system, and that's how the heart rate is being regulated. So when you talk about the sympathetic stimulation, for it increases the sinoatrial activity and it enhances the atrioventricular node. So all this helps in the pumping, the contraction and the relaxation of those chambers to release the blood out of the heart and also to expand to receive blood which comes back to the heart. So regulation of the heart rate is basically looking at these different key things. Let me say the sinoatrial node, which is the pacemaker and is the one that initiates the electrical impulses. Then we talk about its control, how it's being controlled. It's basically the autonomic nervous system that controls the heart rate, that controls the function of the heart. So it is controlled autonomically within itself. Then we talk about the sympathetic stimulation. For it just helps to increase the sinoatrial node activity, which enhances the atrioventricular node. So all this is basically looking at the nervous system. That's how the heart rates are regulated. The cardiac cycle and the sounds. Let's look at the cardiac cycle and its sounds. So the cardiac cycle is a process of filling and emptying the heart's chambers, two phases, that is the diastole and the systole. So when you look at the cardiac cycle, there is refilling and emptying of the heart. So when the heart pumps blood out of it, that is emptying the heart chambers. Then when the blood is received into the heart chambers, that is refilling or filling up of the chambers of the heart. So there are basically two phases, the diastole and the systole. So when you talk about the heart sounds, our hearts have sounds, and we are able to differentiate the normal heart sounds and the abnormal heart sounds. And that's when you can be able to tell whether your patient's heart is functioning normally or it is not functioning normally. So when we look at the heart sounds, we have already mentioned about filling and then emptying of the heart chambers, and it's in two phases, and the first one is diastole and the second one is systole. So what happens during the time of the heart sounds, or during the time when the heart is filling or when the heart is emptying? So when you look at the diastole, that is now the relaxation phase. When it relaxes, there is closure of the atrioventricular valves, and that is the sound that it produces, in brackets loop. So the loop is just like the diastole sound. Then systole is during the contraction phase, and it causes closure of the semilunar valves, and it says doop. So loop, doop is basically looking at the sounds of the heart. So when it says loop, that is the diastole, and then the doop is the systole. So diastole is basically at the relaxation phase when the atrioventricular valve is closing, and then the systole is when there is a contraction phase, when there is closure of the semilunar valves. So the normal pulse rate. What could be the normal pulse rate? So when you're assessing your pulse, you need to know the normal pulse rate. So when you don't know the normal pulse rate, then you'll not know even the abnormal. You'll not understand that your patient is having abnormal pulse. So the normal pulse rate is ranging from 60 to 100 beats per minute, and in brackets is called BPM, beats per minute, BPM. So when somebody has put a pulse equals or is 60 BPM, it means the pulse is 60 beats per minute. What could be the abnormalities of the pulse? One of them is bradycardia. Bradycardia is below 60 beats per minute. Brady means below normal. So when the pulse is below 60 beats per minute, that is called bradycardia. Then when the pulse is above 100 beats per minute, that one is called tachycardia. So all these terms mean abnormal pulse rates. One, the brady is below and the tachy is above the normal range. So where do we take our pulse? So for the case of pulse assessment, we are looking at this diagram, and this one is taking it from the radio, whereby the nurse or the health worker is first feeling it, and you have to identify, and you can see how she's holding the wrist of her patient, trying to identify the pulsation of the radio artery. So after identifying it firmly, and you've realized that this is the artery, the radio artery, then you can start counting it for 1 minute. Then after 1 minute, that is when you consider that those are the pulse of your patients. So the sites include the radio, which is shown in the diagram, where the health worker is actually holding the wrist of the patient, trying to identify the artery. Then you have the brachial. Brachial, that one is at the elbow, just in the middle of the two. When you look at your elbow and then you put your wrist, your hand, your fingers, then you try to identify the pulsation. So the brachial, when you look at the anatomical view of the brachial artery, then you're able to identify where it is. And when you identify where it is, then you can start counting your pulse. Then the carotid, you know where the carotid artery is. So you put also your fingers around that area and you start feeling. Then the apical, the femoral, the popliteal, the posterior tibial, and then the dorsalis pedis. But the most commonly used areas are the radial, the brachial, and then the carotid artery and the femoral arteries. That's where the major that's where people majorly take the pulse from. So when you look at this diagram, it really shows you where the patient is being actually measured from his pulse, and that's where the nurse has put her hand to identify the radio artery. So in most cases, for us who have always interfaced with our patients, I believe that is the major site that most of us have always used during the time of doing pulse assessment. So we look at those areas, and that's why we are able to read our pulse. But there are those common areas that we always use, but there are those that are not common. You can only use them if really you have failed to identify the radio, the brachial, the carotid, and the femoral arteries. So the peripheral pulse assessment, how do we assess the pulse of our patients? So peripheral pulse, a pulse palpated at a peripheral site influenced by various factors. When you look at the previous slides, you can look at how the health workers put her fingers, and those are the parts of her fingers. You don't use the tips of your fingers, but use the pads to identify the artery. So when you see where she has put her fingers, the pads of her fingers, and she places them firmly in that area, that means she is going to take the radio pulse. So those are peripheral pulse. So you have to look at the site, be able to identify the artery, and be able to actually count those pulse for the beats for about 1 minute. Then there you can be able to consider that those are the pulse of your patient or your client. So it's also influenced by various factors. So the pulse is influenced by various factors. When you're taking the peripheral pulse assessment, when you're doing it, you have to consider other factors. So the pulse description, you have to know the rates of the pulse, you have to know the rhythm of the pulse, you have to know the amplitude. The amplitude also is very key. Then the strength of the pulse and the equality of your pulse. So what I want to emphasize mostly is the rate of how many beats, how much have you counted, how many have you counted in 1 minute? Is it within the range or it is above? And what could be the reason as to why your pulse rate is below or your pulse rate is high? Then the rhythm is also very key. You have to know the rhythm of your pulse. You have to know whether it's consistent or it reaches somewhere and it slows. Then again, at a certain point, it becomes very high. Then there you should know that there is a problem with your patient's pulse. Then the strength. The strength of the pulse is also very key, because you need to know whether it's bounding or it is very thready. And when it is a thread, what could be the reason? Is it that the patient is getting into shock? Was your patient bleeding? And how are you going to address that? So when you look at the rate, the rhythm, the strength, they are very key when you're carrying out your pulse assessment from your patient. So when you look at the abnormal findings, what could be the abnormal findings? So the abnormal findings interpreted in light of the patient's health status and baseline rates. So we have to look at the baseline rates. The baseline rates can be the normal, the cutoff points, or the cutoff ranges of the pulse. So when you see that this patient is supposed to be having a 60 to 100 beats per minute of the pulse, then you're seeing that the patient is getting below, then you should know that there is something that is happening to your patient. So interpreted in the light of the patient's health status and baseline rates. So the baseline rates is within 60 to 100, but now when you see that they are below or they are above, then you just know these are abnormal findings. Then also you have to look at the patient's health status. Sometimes the patient comes and the patient has overbled, the patient is dysemic, the patient is restless, the patient is actually showing signs of bad condition. Then also you may get abnormal findings of your pulse. So the pulse has to be interpreted in relation to the status of your patient and also in relation to the baseline rates of the pulse rate. Then pulse strength grading. How do you grade the pulse strength of your patient having taken them? 0 when there is none palpable or absent. So when you try to look for the pulse of your patient and you are not feeling them, and we want to refer this to the picture where they were looking for the radial pulse at the radio artery to count the radial pulse. So when you're looking for this and you're not getting it completely, it is not pulsating, you don't feel even any threadness, then you put it as 0, it is absent. Then +1, that is not the diminished, weak and barely palpable. So when you try to touch, it's very weak, and that one is where they say very thready or thin pulse. So you are not feeling it completely, and you cannot palpate even the artery, and you end up just saying maybe it is +1 because it is very slow, it is so thready, and you barely or you hardly palpate it. So you put it as a grade of +1. Then when it is very strong, when it is strong, that one is +2. Then there is where it is high, and also when it is again high, increased, it is not good, and that one can give you a sign of high blood pressure passing through that blood vessels. So it is given a strength of grade 3 plus. So this one you start querying the condition of your patient or the state of your patient, the health status of your patient. Then +4 when it is pounding. Pounding, you can even just look at the artery. You look at the blood vessel, you've not touched it, but you are seeing it pounding. You're seeing how the blood is flowing through the arteries, through the blood vessels. That one you grade it as 4 plus. So that's how we grade the strength of the pulse when you are taking the pulse assessment. So we need to grade, and when we grade, the grading will help us to actually understand the patient's health status and also interpret in relation to the baseline rates of the pulse. So I want to continue in the assessment, the peripheral pulse assessment, and you're supposed to check for equal strength bilaterally, and can give you it can be significant if unequal. So it can give you a picture of something that is happening normally or abnormally. So if you've checked the pulse on the other side of the wrist, that is on the radial pulse, and you have counted or you have realized that there is some deviation in the number of pulse, in the rate of the pulse, the strength of the pulse, and the rhythm of the pulse, then you can also change to the other side and see whether it is the same or they are different, and there you can also try to guess what could be happening with your patient. Then apical pulse, taken at the apex of the heart. Apical, it means the apex of the heart. So when you're taking it, where are you going to identify this pulse from? It's at the fifth intercostal space. The fifth intercostal space is just basically at the mid clavicular line. So when you touch there at the fifth intercostal space, you're able to feel at the pulse, you're able to feel the heart rate. And when you touch it, and you're able to count, you can also be able to differentiate the normal from the abnormal. So the apical pulse is basically taken from the apex of the heart, and that is at the fifth intercostal space. Then pulse deficit. What is pulse deficit? Pulse deficit, this one is the difference between apical and peripheral pulses. So it may indicate certain cardiac conditions. So when you look at that, there is difference between the apical, that is from the heart, and then the peripheral pulse. The peripheral pulse is basically looking at you taking this pulse from either the axilla, taking this pulse from the oral site, from the femoral, and so forth. So when you do that, you're able to identify the difference between this peripheral pulse and then the apical pulse, and you'll be able to tell what could be happening from your patient, and you can be able to identify that there should be a condition in the heart. So apical pulse gives you directly what is happening in the heart. When you take the apical pulse, it will tell you exactly what is happening with your heart. But when you take the pulse from either the radial artery, the femoral artery, and then maybe the carotid, all those ones are from the peripheral, and they may not actually be the same as the pulse you have taken from the apical pulse. This pulse may be different. So there you can also be able to understand what could be happening in the different sites, and it can give you an indication of maybe a problem that could be happening in your heart. So which ones are the different pulse sites? When you look at the different pulse sites, we want to talk about the brachial, and that one we can use the infants, and also we can use at the blood pressure. So when you're taking the BPs, we can be able to tell if the BPs are high, then also the pulse rate will be high. When the BPs are normal, then the pulse rate will be normal. When the BPs are very low, sometimes the pulse rate will also be very high again, or it will also be steady. So it's very important for us to know the sites and also to understand the impact of taking this pulse from those different sites. Then posterior tibial and then the dorsalis pedis, that is at the lower limb, and then it helps us to identify the circulation assessment. So when you have very low pulse at these areas, then you can be able to also understand that there can be a decreased circulation of blood towards the lower limbs or the lower uh, the legs. So when you're taking this pulse, you should be knowing the rationale of the sites in relation to the circulatory system, or in relation to the pulse, in relation to different aspects, so that you can be able to assess your patient well and manage your patient. So the posterior tibial and the dorsalis pedis is basically at the lower limb, and this one can help you know what is happening in the lower limbs, whether there is good circulation of blood to the lower limbs or not. So it helps us in assessing our circulatory system from our patients. So what could be the assessment tips? The assessment tips is basically trying to tell us how we are going to carry out the assessment of the pulse in those different sites. So one, use the index and middle finger. So the index and the middle finger are the ones that you are going to use to identify and palpate where your blood vessels are on the sites that you're going to take your pulse from. But you don't use the tip of the middle and the index finger, but you are going to use their pads to palpate and feel for the pulsation of those blood vessels in those areas. Then gently but firmly press for 30 or 60 seconds. So when you identify, you firmly press, and when you press them, you are able to actually hold them firmly before you start at the counting of the beats of the pulse. So you gently and firmly press for about 30 to 60 seconds after you have identified. Then assessing apical pulse if peripheral is rapid or difficult to palpate. So when you find that it's very difficult for you to palpate the peripheral pulse from either the radio or the brachio, then you can also go ahead to look for the apical pulse so that you can be able to identify or to know what is happening in the circulatory system, what is happening in the heart, and be able to address. So assessing apical pulse if peripheral is rapid or difficult to palpate. So that's how you end up using the apical pulse. So when the peripheral is difficult for you to identify or palpate, then you can go and use the apical pulse. So the other vital that we are going to look at, the vital sign, is respiratory and oxygenation status. So respiratory components, what are the respiratory components? So we have ventilation, whereby we look at inhalation and exhalation. Inhalation is taking in of oxygen and exhalation is bringing out of carbon dioxide. So ventilation is key in the respiratory system. Then pulmonary gas exchange is also very key, and this one happens in the lungs. Then gas transport. Gas transport, we are looking at it in relation to the circulation of the blood within our bodies, whereby the oxygen or the gas is being transmitted or being transported within the circulatory system. Then peripheral gas exchange is also very key for us to know within the circulatory or the respiratory system, and in relation to the respiratory components. So we are looking at this all, and that's where we are able to know whether our patient has a normal respiratory rate or not in relation to these different components. So how are we able to control the respiratory and oxygenation status of our patients? The control of this respiratory and oxygenation status is basically voluntary and involuntary. So primarily it is driven by carbon dioxide levels in the blood. So when we have no carbon dioxide in our blood, then also it is going to affect the respiratory system and the oxygenation status of our patients. So the presence of the carbon dioxide levels in the bodies or in the blood of an individual is able to actually help in regulating the respiratory rates and the oxygenation of the blood of our patients. And when we don't have carbon dioxide in our bodies, it's going to affect very, very much the oxygenation status of the blood within our circulatory system or within our bodies. Our respiration assessment, how are we going to assess the respiration assessment? How are we going to do it? We are going to count for 1 full minute. So you just observe the chest of the patient and then you count, but don't let the patient know that you're counting his respirations, because he can change the position, he can become anxious and starts actually breathing very fast, or even stop the breathing, and this can affect the counting of the rates in that 1 minute. Then use a stethoscope against the chest for rapid rates. So when there is a rapid rate, then you may end up using a stethoscope to count or to know what is happening in the chest of the patient, so that you can be able to address the rapidness or the cause of the deviation of the normal rates of these respirations of the patient. Then consider the age, clinical state, and emotional status. So you have to look at the age of the patient. The ages of our patients also contributes to the different ranges of respiratory rates, and then also the clinical status of our patient can also contribute very much to the respiratory rates of our patients. And then the emotional status, when someone is anxious, someone is scared, this can increase the respiratory rates, and you may think the patient is having a respiratory problem, and yet actually the patient is anxious and the patient is maybe scared. And then the normal respirations, evenly spaced, quiet, meets the body's needs, and no accessory muscle use. So when the patient is having normal respirations or the patient is breathing normally, you find that the patient is quiet. There's no sound in the chest of the patient. When the patient is breathing in or breathing out, you don't realize any sound, you don't hear any sounds. And then also it's able to meet the needs of the body, whereby when the patient is having enough oxygen, you realize that the extremities are well perfused because the oxygen is enough, the patient is breathing in enough, and there is enough saturation of oxygen in even the circulatory system and well distributed in the entire body, including the vital organs. So you realize that is able to meet the body's needs when the patient is breathing normally. Then no accessory muscle use. So when our patients are breathing normally or they are having normal respirations, even the accessory muscles are not used. The patient is not having any labored breathing. The patient is just calm, but the respiratory rates are very normal. The patient is calm, and all the needs of the body of the patient are met. Then the abnormal respirations, what could they be and how do they present, or how can you identify that your patient is having abnormal respirations? The abnormal respirations are characterized by slower, they can be very slow, below 16 or even below 12, and also they can be very fast, above 20. You find the patient, an adult, is breathing about 30 breath per minute, 60. So you realize that there is an abnormal respiration. The patient is having a problem. Then also you may realize that there is labored breathing. The patient is breathing with a lot of energy, is using the accessory muscles, he's really struggling, and you realize there is a problem because there is labored breathing where he's using all his energy trying to grasp the oxygen and to help to meet his body needs. So abnormal respirations are characterized by slower or faster, then also labored or noisy breathing. There can be some noisy sounds that can be produced when the person is breathing. Then you realize that there is an abnormal respiration and there is a problem in the respiratory system. Then in the assessment, you have to consider respiratory rates in relation to the age, clinical state, and emotional status. So when you're counting or you're considering the rates that you have counted, you have to look at the age of your client, you have to look at the clinical status of your client, and also you have to look at the emotional status of your client because this can affect the respiratory rates of your patient. Then assessing respiration and oxygenation. It's very key for you to know the respiration and the oxygenation. So when the patient is breathing normally, you mean the patient is taking in enough oxygen and there is no problem with the breathing. It's not fast, it's not slow, it's not labor, there's no noise. Then you realize also this patient is having enough oxygenation. There is enough oxygen in the circulation. But if this patient is struggling with the breathing, this patient is laboring with the breathing, this patient is actually struggling, the breathing can be very fast and there's also some noise, then you realize also the oxygenation is affected. So when you're assessing the respiratory rates of this patient, you have to put into consideration on the oxygenation. That's why you have to have also the pulse oximeter so that we can be able to assess the oxygen percentage that this patient has within his circulatory system or the blood system. So respiratory and oxygenation status is very key. So the basic assessment is to count and determine adequately what are the respiratory rates of this patient. So when you count adequately the respiratory rates of this patient, you can be able to tell the normal from the abnormal, and you can be able to intervene immediately or appropriately to save the life of this patient. So let's talk about assessing the rate, rhythm, depth, and pattern. So these respirations are supposed to be assessed, just like the way we talked about the pulse. We have also to talk about the rates. How many respirations per minute? What is the rhythm? After one breath, how long does it take for this next breath to be actually taken again? Then, in case you have assessed the rhythm, what is the depth? Does the patient breathe and actually completes the breathing? Does the chest go in normally, or the chest does not go in normal? The patient is feeling pain and they may end up with a shallow kind of breathing, whereby it doesn't allow the chest to go in the way it's supposed to, and it remains just in the middle because he's feeling pain. Or it's whereby the patient has irregular kind of respirations. He breathes very fast, and those are the patterns. He breathes very fast, then after taking maybe 5 breaths very fast, he again starts to breathe very slowly, and you realize the pattern of the breathing is not a normal one. As you assess the rates, you have to look at that. So you assess how many breaths, what is the rhythm, and what is the depth of the breathing. Is he taking that enough breath? Does it go deep? And as he breathes out, does it come out complete that he releases the carbon dioxide, or the patient breathes and he gets those shallow kind of breath? And also the pattern should be regular, not irregular. So you also have to listen for adventitious sounds. These are the sounds that are abnormal. So this can be the abnormal sounds like the crackles. Crackles can be in the chest around the lungs. Then also the rhonchi. The rhonchi can be within the bronchi uh, of the lungs, and you can feel there is a sound as the air is going in or coming out. Then the wheezing. Wheezes are basically more in relation of the obstructed airway, and also it can be due to the conditions like asthma, due to increased secretions on the bronchi, and it has obstructed the lumen, and now the oxygen is trying, the air is trying to pass through, and the patient ends up producing that sound during the breathing out. And you realize these adventitious sounds are actually very abnormal sounds. So when you hear crackles on the chest of your patient, you hear the rhonchi from the chest of your patient, and you hear the wheezing as you're listening to the sound that comes out of your patient, you should be able to understand that your patient is not well. So that's why it is very key for you to know the normal sounds and the abnormal sounds, so that you can understand if your patient is able to take enough oxygen, or you need to intervene by putting oxygen therapy for your patient to improve the oxygen saturations. Then check on the SpO2. The SpO2 helps us to know how much oxygen the patient has. So we should also be able to understand the normal percentage of the oxygen levels that we need in the normal patients, or the normal people, or the cutoff range of the oxygen saturation, so that we can be able to identify the abnormal and intervene appropriately. Then note the presence of coughing or sputum. So when the patient is also coughing, or the patient is producing sputum, then that can also give us an indication of a problem in the respiratory system, especially in the lungs. So the pulse oximeter, as you're seeing in this slide, the pulse oximeter is basically where this patient or the health worker has put the finger, or they are checking the oxygen saturations of the patient, and he has put his middle finger. You can see this is the index finger. He has put it. So the part of the pad is the one that is supposed to be put where there is light, and when you put it where there is light within the tool or the machine, then it will be able to give you the accurate readings. So it measures the percentage of the hemoglobin carrying oxygen to body tissues. So when you look at this, you're able to give the readings, and you're able to see that this patient is having low oxygen, and you're able to see this patient does not need oxygen administration. Then when you see that they're abnormal, then you have to help improve the oxygen saturation of this patient by putting a patient on oxygen to increase the oxygen saturations. So I want us to see what these other terms are. And the first one is cyanosis. What is cyanosis? Cyanosis is a blue or pale tone indicating poor oxygenation. So when the patient's extremities are cyanosed or the skin is cyanosed, or sometimes you can even realize the lips, the mucous membranes of the mouth are cyanosed, then you know that this patient is having little oxygen, and this is a clear indication. Then may be noticeable below 85% SpO2. So when the oxygen levels, when you measure using this pulse oximeter and it's showing you the measurement or the percentage is 85 below, then you know that this patient is having low oxygen saturations. Then a late sign of respiratory dysfunction. The patient can start breathing very fast or having a difficulty or labored breathing, then you realize that there is also a problem, and this can contribute to low oxygen saturations. Then the other thing is the central versus peripheral cyanosis. So the central and peripheral cyanosis can help you also differentiate what could be happening in your patient's heart and what could be happening in the extremities. So this one can show you and can also help to guide you in the management of your patient. So we have to put this in consideration, looking at the central versus the peripheral cyanosis. So these are very, very important things that we have to consider, and we have to actually put into consideration as we are managing our patients, and this can help guide us even in the management of our patients. So So I want us to also look at the other thing besides the cyanosis. What do we have to also put into consideration when we are measuring the pulse of our patients? And also we have to really understand when the color of the patient is like this, what does it mean? When the patient is expressing himself in this kind of breathing, what does it mean? So that we can be able to manage our patients appropriately and adequately. So we have to look at this pulse oximeter. So this pulse oximeter is basically the tool that we use in managing or assessing the oxygen levels of our patients, and we are able to intervene adequately, because when the patient has low oxygen levels, that means we can even lose the patient. So breathing is very, very key in the management of our patients, and that's why all facilities should be able to have a pulse oximeter that can help us monitor the oxygen levels of our patients. So utilizes red and infrared light beams through body tissues. So when you look at the pulse oximeter, as I earlier on started by saying, it has some light inside, and when you open it and you put the light on or you switch it on, it shows some light beam inside it, and that's where we place the pad of the finger, and it will be able to take up the readings. So it transmits signals to a computerized unit, which will help interpret the readings and be able to know the amount of oxygen that is in the circulation. Then also it measures wavelengths that is altered by oxygen saturated hemoglobin and applied to translucent areas with the pulsating blood flow. So pulse oximeters are very, very good, and we use them in all age groups, and we can use them in all patients to assess the oxygen levels of our patients. So what could be the factors that can affect the respiration? There are different factors that can affect the respiratory rates of our patients. For example, the age. Children have a higher respiratory rate than adults. So you cannot compare the respiratory rates of children to the ones of the adults. The adults have a moderately lower respiratory rates, while the children have a higher respiratory rates. Then also we have to look at the gender. For the case of gender, women tend to use intercostal muscles more than the men. So this is also we have also put this into consideration so that we don't say that the woman has maybe labored breathing, she's using accessory muscles and so forth. So for the case of gender, women tend to use intercostal muscles more than men. Then also the time of exercise. When people do exercises can also increase the respiratory rates. It depends and increases the breath rates of the person, and that one we can't say that the person has difficulty in breathing, but it's due to the exercises that the person has been doing, which have increased the breath rates of the person. Then acid base balance, we look at the alkalosis, which slows breathing, and also acidosis, which accelerates. So sometimes they take measurements of this, and when they realize that the patient has alkalosis, the breathing can actually be affected. And then on the case of the acidosis, also the breathing can be affected, but in different ways. For the case of alkalosis, increased alkalosis, there is a low increased levels of alkaline in the blood. It may end up causing the patient to have a low breathing rate. But when there is a lot of acidosity or acid in the blood, then the patient may end up having increased respiratory rates, which will be accelerated, and this one is not normal, and there is need for intervention. Then anxiety, this one is emotional. The patient might be anxious, and this can cause faster breathing and hyperventilation, increasing the respiratory rates. So respiratory assessment are parameters. You have to look at the rate, the rhythm, the depth, and the patterns of the respirations. Then the factors influencing the respiratory rate, we have already talked about it, and respiratory rates are abbreviated as RR. And for that reason, we have the different factors that can affect the rates of our respirations. One of them is exercises, and I think I've already mentioned about the exercise, whereby some exercises, when we do them, they can affect our respiratory rates. And when they affect the respiratory rates, it doesn't mean that we have a problem with the breathing, but it's only because we did the exercises whereby we need to increase the intake of oxygen, and therefore the rate of breathing has to increase. Then medications, some medications can also affect our respiratory rates. So we have to know whether the patient has taken any drugs, and what drugs, and what is the mechanism of action of those drugs in relation to the respiratory system. Then anxiety, if your patient is anxious, and that's why when we are taking these vital signs, the patient has to be in a calm, quiet environment, so that when you are taking the pulse, when you are taking the respiratory rates, when we are doing whatever we want to do in relation to the vital assessment, the patient is actually calm, not anxious, which will affect the rates. Then the pain can also affect, and pain is very, very bad in relation to the vital signs, because the patient will not be comfortable. The patient will actually end up disturbing, the patient will end up restless, and this can increase the respiratory rates. Then body position also matters as you're counting the patient's respiratory rates. So what are the abnormal signs? When your patient is presenting with the abnormal signs or bad breathing, there are some signs that can be seen clearly from the patient, and you'll be able to tell that this patient is having a problem with the respiratory system. So one of the abnormal signs is nasal flaring. The nasal flaring, you find the nostrils may end up opening. The patient, as is breathing in, even the nostrils end up expanding, and that is called nasal flaring. Then post lips, the patient tries to pause the lips in order to grasp or to take in some increased amount of air. And by doing that, you realize there is a problem or there is difficulty in breathing, where the patient is trying to take in enough oxygen to help him or help her in survival. Because when there is little oxygen, we just know that life is compromised. Then cyanosis, we can also realize that there is cyanosis, orthopnea can also be there, and then confusion. Because there is little oxygen, the patient gets hypoxia due to decreased supply of oxygen to the brain, and that helps, that causes confusion, and the patient can easily become restless. How do we assess the oxygen saturations in our patients? So oxygen carrying capacity in the blood is very important, and we measure it in percentage. And I remember we talked about the pulse oximeter. And the pulse oximeter is basically the equipment that we use for measuring the oxygen levels in the bodies or in the blood of our patients. So the measurement, we have to utilize a pulse oximeter, and also we need to know the normal ranges. So the normal ranges of oxygen in our bodies or in the blood, in the circulatory system, is supposed to be 97 to 100%. So when it is below 97, then you should think of something going wrong with your patient. So what could be the considerations? For patients with chronic breathing conditions, we need to maintain them at the saturation levels of 90%, and this one is acceptable. But below that, then you should know that your patient's condition is deteriorating. So this can only be maintained when you put our patients on oxygen therapy. So here we are going to talk about now the blood pressure assessment as one of the vital signs that we need to assess uh, within our patients when they come. We need also to take their blood pressures. We need to assess the pressures of our patients, and this can help us in the management, and this can help us also in the diagnosis. So what could be the components of blood pressure assessment? We need to know the systolic, we need to know the diastolic, and we also need to know the normal ranges. For the case of the systolic, which is the above figure, it should be less than 135, and then the diastolic, which is the below figure, it has to be at least below 85 millimeter per mercury. Anything that is above that is going to be high blood pressure. So we need to regulate. How does our body regulate the blood pressures? We know that blood pressure is supposed to be in a certain level as being normal. But then if it goes high or it goes below the normal, then the body has to regulate. So we have the hormonal effects or the hormonal influence in the regulation of our blood pressures. When you look at the hormonal influence, we are going to look at the baroreceptors. These ones are the reflexes that help to influence the blood pressures. But within that, we also have to know and to understand that the mechanoreceptors are the ones that allow the relaying or the transmission of information that is derived from the blood pressure within the autonomic nervous system. So when the information is passed into the brain, then to be able to coordinate, and we shall be able to know that the pressure levels have been increased or the pressure levels are low when we take the measurements. So the baroreceptors are very key in relation to influencing the blood pressures, and the mechanoreceptors are very key in relation to passing the information from our blood vessels where there is increased pressures, into the autonomic nervous system so that it can be able to be reflected to the brain. And when you take the measurements, you'll be able to get the readings that will tell you or will help you interpret actually the normal levels of the blood pressures that your patient has. Then also we want to look at the renal baroreceptors. Besides the mechanoreceptors, we also have the renal baroreceptors that detect the decreased arterial pressure within the afferent arteriole. So the afferent arteriole, basically we look at the renal system, and that's why we find the afferent and the efferent arterioles. But here we are looking at the afferent arterioles that helps us in detecting how our blood pressures are either increased or decreased. But here the renal baroreceptors look at mostly the decrease of the arterial pressures, and we can be able to understand and to know that the pressures have decreased. That's why I want to give an example for the pregnant mothers. The pregnant mothers, when they have high blood pressures, their renal system is always affected because the renal system, for it being able to detect the decreased arterial pressures due to the baroreceptors, it's mostly affected when the pressures are very high. So it causes damage to the kidneys, it causes acute kidney injuries because the pressures are very high, and you can easily identify them when the patient is put on a catheter and the blood which is, the urine which is coming out is bloody. That means the pressures are very high and this patient needs an intervention. So the renal baroreceptors helps us to detect the decreased arterial pressure within the afferent arterioles, and when the pressures are very high, there is always an injury or there is a negative impact onto the renal system. So we also have to talk about the activation of the RAS. The RAS is just the renin angiotensin aldosterone system, which helps in regulation of the blood pressures. So its regulatory mechanism for the blood pressures that we have in our bodies are also a way of controlling the fluid and electrolyte balance through the coordinated effects on the heart. So when there is an effect or there is a negative impact on the RAS, it will always affect the regulatory mechanism of the blood pressures in relation to the fluids and then the electrolyte balance in our bodies. So the heart helps in blood saturation, and also helps us to regulate the amount of the fluids and the electrolytes in our bodies. So when this one is affected, it will actually show us that there is a problem in the blood pressures in our bodies. So the higher blood pressure when it is taken at the doctor's office than at home. So when we take these blood pressures, sometimes patients at home of course don't take their pressures. So these pressures are taken basically in the hospital. But when we take these pressures, we don't take once and we consider that the pressures are high. So we take maybe more than 2 times, and when you take it more than 2 times, we realize that there is increase of the systolic by either 10 to 30%. So when these pressures keep increasing, then you know that this patient is having increased levels of high blood pressures. So there you can consider this patient to be hypertensive, and when the pressures keep increasing, then you start suspecting until you confirm with the several tests or several measurements, not just taking once and you say that this patient has high blood pressure. So you should take maybe 2 to 3 times, and if you see that they are keeping on increasing by 10%, 30%, then you just start suspecting this patient to be hypertensive. So the normal high blood pressure is supposed to be the diastolic. The systolic being the top one is supposed to be less than 130, but should also not be again below 90. Then the systolic should be at least less than 85, but should not again be below 60, depending on the status of your patient, the environment, and so forth. But we should always look at this as very, very important when we are looking at the increase. If it is increasing by 10%, the systolic, and maybe by 15%, the diastolic, or 30%, then we should know that our patient is getting into hypertension, and we should be able to monitor this patient critically so that we don't get the patient when the patient is actually very ill. So monitoring of these vitals is very important so that we can be able to intervene in time before the condition goes out of hand. Then high normal, this is 130 to 139, that is for the systolic, and then 85 to 89 for the diastolic. So within that range, it is within the normal, but it's high normal. So there you have also to know that this patient is at the boundary of getting into hypertension. Then grade 1 hypertension, that one, the diastolic is 140 to 159, the systolic, those are the systolic measurements. Then the diastolic is 90 to 99. So when you look at the grade 1 hypertension, you have to put these figures in consideration, where the ranges will be like 140 to 150, the systolic. Then you start suspecting that this patient is having grade 1 hypertension. Then the diastolic 90 to 99, that is really abnormal. So you have to start seeing how to manage this patient depending on maybe the exercise, the feeding of the patient, and some of them may respond and they can get back to their normal pressures. Then grade 2 hypertension, the systolic is 160 to 179, and the diastolic is 100 to 109. So when you see the patients coming to you and take their vitals, their blood pressures, and they get into such ranges, then you should suspect that this patient is already in grade 2 hypertension, and you need to intervene to save the life of this patient and further complications. Then grade 3 hypertension, that one is greater or equal to 180 systolic, and then the diastolic can be greater or equal to 110, which is really very high, and the patient can be prone to several complications like stroke, and also can get into cardiac arrest, and we may end up losing these patients. So grade 3 is so bad, and if it is not well managed, then the patient will end up with isolated systolic hypertension, which is greater than, and will continue persisting. And even when you give drugs, these patients sometimes not respond because their conditions have left to go beyond boundaries of management. And those are the patients who end up with a stroke, and those are the patients who end up with clots in the brain. These are the patients who end up having cardiac arrest and heart failure, and we end up losing them just because we did not identify in time. And also the culture in Africa, most of us don't do health assessment for ourselves. People don't go to the hospital, they only go when they have seen that they are sick. But when someone is not feeling sick, nobody actually goes to the hospital just to do general checkup. So this is the diagram of the blood pressure machine, and when you look at it, it has the labels, and we should be knowing where we place each part of this blood pressure machine. So here is the cuff. This where my arrow is, the cuff I mean. This one is the cuff, and this cuff has different labels. They have labeled them, the different parts of this cuff, and this is the adult size of the cuff. And here you're seeing here, this is the artery indicator label. This is where you're going to put when you've identified the brachial artery. This is where you're going to place it, and when you place it, you know where the arrow is. The arrow is facing down, so this arrow should be facing down, and this other part should be facing up, so that you can be able to get appropriate readings. And then you see this part is the inflation valve, where you're going to pump in the air, and this one is the air release valve, where you're going to help actually in the regulation of the amount of the air that you have pumped. As you're listening, with your stethoscope to help you hear the first sound, which is the loop, and then the second sound, which is the loop, and the first sound, which is the loop, is the systolic readings, and then the loop, which is the diastolic, having mentioned, is the second actually sound. So when you get those readings, you are able to know which one is normal, which one is abnormal. Is the patient having high blood pressures or not? Is my patient hypertensive, or he's having normal pressures? So you just have to look at this machine, and then you get to know the different labelings in these different parts of the machine. So measurement device, you can see how the patient is seated, and then you can see how the patient has placed his hand comfortably, and then the health worker is able to place the stethoscope, and this part is the drum, and is able to actually listen for the sound as it's pumping in the air and releasing. So the mercury blood pressure machine is also this side. So for the case of this one, for it, you have to actually pump in the air, and as you're pumping in the air, you have to observe how the mercury is moving, and you should always pump the mercury up to certain levels or certain readings. Maybe even you can pump it up to around 180, 170 before you start releasing it, so that you can be able to assess whether a patient has high systolic or high diastolic readings. So where you start hearing the sound, that one is the systolic. So you read the mercury on those figures where it has reached that level. You see the figures which are in that level where the mercury has reached as you hear that sound, the first sound, and that is the diastolic reading. As you continue releasing, where the sound fades off, that one is now the diastolic, and you read those readings where the mercury has actually ended as you hear the sound, and that one will be the diastolic readings. So the BP curve and auscultatory gap should also be put into consideration. So the BP curve, that is the inflatable bladder, and its considerations have to be actually noted, whereby you have to put it in the right place, and that arrow which I talked about has to be facing down. So you have to identify first of all where the artery is before you start placing the cuff, and then you start inflating it up to the maximum expected pressures before you start releasing. So you have also to avoid bulky clothing and underneath. So you need not to put the cuff on top of the clothes. So you have to remove the clothes and put it bare onto the body or the skin of the patient, and that's when you'll be able to get the right readings. Then auscultatory gap, a silent interval during the the correct cough sounds, and those correct cough sounds are basically the loop and the doop, and those are the systolic and the diastolic sounds. Then also avoid by inflating an extra 20 to 30 millimeter mercury. So you should not over inflate the cuff, because when you over inflate it, it may cause discomfort to the patient, and also it can cause a damage to the cuff. So you should always know how much you're supposed to inflate before you start releasing, and before you continue increasing the pressures. Orthostatic hypotension is also one of the conditions that we get in patients who are having hypertension. So we need to keep checking. So checking orthostatic hypotension, first check in a sitting position, and this one is basically looking at the kind of position the patient is in. So the patient can be seated, and when you take the pressures, they can be very low just because he's sitting, and then when he stands up, the pressures increase. So this one is due to the position of the patient. So you need to first check in a sitting position. It is a form of hypertension that happens when standing after sitting, or lying down. So this can cause dizziness or lightheadedness and possibly fainting. So you need to see whether your patient is having normal pressures when he's seated, and then when he's standing, what are the pressures. So when these pressures raise due to maybe the changing of the position, or when the pressures decrease due to the changing of the position, then you know this is orthostatic hypertension or orthostatic hypotension, which is due to position changing. So check again 1 to 5 minutes after standing. So when you check the patient when the patient is seated, you can also check when the patient is standing, and you'll be able to identify that maybe this patient's blood pressures have gone very low, which is hypotension, and it will be called orthostatic hypotension, because the patient had normal pressures when he was lying, but now the pressures have become low when he's standing. So this hypotension can present with dizziness, lightheadedness, and even the patient can easily faint for you. And more commonly, the patients who have bled. When a patient has bled, like the mothers, when they get PPH after delivery, it's very risky for you to make her stand, because she can get this orthostatic hypotension, and she can easily faint for you in the ward. So in blood pressure assessment, it fluctuates, and so the fluctuations occur with exercise, medications, physiology or illness. So all these different vital signs can have their own fluctuations. They can deviate from normal to abnormal depending on some factors in relation to each of them. So for the case of blood pressure assessment, exercise, medication, and illness can affect the blood pressures. So interpretation, you need to know the patient's normal pressures, and then considering the factors like hypertension, kidney disease, heart failure, diabetes, and orthostatic hypotension, so that you can be able to interpret your results very well and come up with the right diagnosis or suspect of the condition of your patient. So average variation, when you look at this table, it's going to tell you the variation of the blood pressures in relation to the age, and then the pulse, the respirations, and the BPs. So in relation to the age, the newborns, what are their pulse, what are their respirations, and what is their BPs. If the child is 1 to 3 years, what is the pulse, normal pulse, what is the respirations, and what are the BPs. So you can be able to tell the different variations of respirations, pulse, and blood pressures of patients in relation to their ages. And when you get them and they have those kind of either variations, it will not be a cause of alarm, because you already know that the ones who are very young, their pulse rates are always high than the elderly people. Even their respirations are high than the elderly people, and their blood pressures are lower than the elderly people. So these variations can help us understand our clients basically in relation to their age when you look at the health assessment of their vitals. So ambulatory blood pressure monitoring, it involves non-invasive 24-hour blood pressure monitoring during regular activities. Then anerate, this is the blood pressure monitoring without the liquid. So we have different types of blood pressure machines, and we use them in assessing our patients in different times and in different situations. So in the case of the ambulatory blood pressure monitoring, this one involves non-invasive, and it can be used in 24 hours monitoring of their blood pressures. You can use this for 24 hours when there is no interference, and you can be able to tell the vitals, especially the blood pressures of our patients at all times. Then this anerate, this one is basically blood pressure monitoring without the liquid. So when you look at these types of blood pressure machines, they are very different. There are these ones which are so digital. When you just tie and you pump in the air, it just reads. And there are those ones you just tie, and when you tie, you just switch it on, and then it pumps the air itself in the cuff, and it just tells you the readings. And then and it does not have the mercury. It does not have the mercury, and that is the liquid for it. It just reads automatically. It has cells, and that one is good for those who want to use them for monitoring themselves at home. So these machines have different ways in which they are used, and they are actually used in different situations in managing the patients. Those who are able to monitor their blood pressures at home can use this other automatic one, which does not have the mercury, because for the case of the mercury, you need to read it. So when you're using it alone for yourself, it may be very difficult for you to read the readings. So vital signs teaching, patient teaching topics, we need to teach the patients the normal values versus the individual values, and we have talked about the individual different age variables. So we need to look at that. So when you are teaching them on the values of the normal ranges in those different vitals, we should also put into consideration their ages. So when we teach them, we have to look at that. Then home monitoring, our patients should also be able to monitor their vitals when they're at home. They should be able to know how their BPs are, especially those who have high blood pressures, hypertension. They should be able to monitor at home, so that when they see their pressures are increasing or they are getting low, then they should be able to come back to the hospital so that intervention is done in time. Then when to seek medical attention, they should also be told when they are supposed to come to the hospital to seek for medical attention. Sometimes they stay at home, they are feeling a lot of headache due to high pressures, they are feeling dizzy, but they are just at home because they don't know that those could be the signs and symptoms of somebody whose pressures have gone high. So we need to tell them when they are supposed to come and seek medical attention. Then the medical effects on vitals is also very key, especially our patients who have high blood pressures, and then the patients who have heart conditions. So when they take these drugs, some of them the pressures can even come very low, and this one can cause problems to our patients more than. And also there are those who can be having heart conditions. When you give them the drugs, it can cause also more problems to the heart. And when we don't tell them those kind of effects, they may end up staying at home when they are not feeling well, and they think it's just the condition, and yet it's the impact or the effect of the medication. So we should also tell them about that. Then symptomatology awareness is also very key, which I've already talked about: dizziness, headache, and all that. Heart palpitations may increase, and our patients may need to come back to the hospital, because when they don't come back, they may end up coming when they have serious complications, and we fail to manage them adequately in saving their lives. Reporting and documenting. So when and what to report. They should be able to know when and what they should report. And even as the health workers, we need to know when and what we should report about our patients' vitals. Then the vital sign record, we need to keep it, because it helps us to know the deviations and the variations when they occur. Is it in the morning? Is it in the evening? Is it when they have taken the drugs or when they have not taken the drugs? At what time do these vital signs actually deviate from normal to abnormal, or when do they derange? So vital sign record is very key, so that we can be able to monitor the care and the management of our patients. Chatting by exception is needed. We need to chat the vitals, like we have the vital monitoring charts. So we need to chat them so that we can be able to tell whether this is normal or this is abnormal. But when you don't chat, you may not be able to really understand the levels and the impact of the different vitals that we take from our clients. Apex of the heart. What do we need to report? So reporting and documenting, when you look at the apex of the heart, what do you need to know? So the tip of the heart used by auscultation to obtain a pico heart rate, that is the apex of the heart. So we always take it from that part, and that's when we are able to know that these are the heart rates, and this is how the apex of the heart is, and it will tell us whether there is any abnormality in the heart or not. Then apnea, what is apnea? Apnea is temporary cessation of ventilation or breathing. So some of our patients may end up with a slurred breathing, and suddenly they can even cease their breathing, and this has happened in most cases, or it is frequent with our prematures, whereby sometimes they stop the breathing, and when they cease the breathing, if there is no immediate intervention in uh, resuscitation, some of them end up even dying. So apnea is very bad, and we need to report and we need to document so that people can take key note and observation on this patient. Then atrial node, atrioventricular node, this one regulates the heart rate and is located between the atria and the ventricles, and that's why the name comes as atrioventricular node. It's located around those two um, valves. So the atria and the ventricle, around those two, and it helps in regulating their functionality. Then auscultatory gap. When you look at the auscultatory gap, what does it mean? It talks about the silent interval that is during the Korotkoff sounds. So in between the sounds, that is called the auscultatory gap. So when this sound when you do when you pump in the air into the cuff and you start releasing it, there is the first sound, and when that first sound um, comes in, that is now what we call the systolic. Then that gap between the first sound to the second sound, that is now the diastolic. So in between those two sounds is what we call the auscultatory gap. Then bradycardia, bradyponia is the same, and we said bradycardia is the heart rate or a respiratory rate below normal. So it's a very low heart rate, and that's why they call it bradycardia. So bradycardia is just a term that signifies that the respiratory rates are very low, below normal. Then the cardiac output, volume of blood pumped out by each ventricle per minute. So when it releases blood out of the ventricle, that is called the cardiac output. So the heart pumps blood out of the ventricle in 1 minute, and that is called cardiac output. Then cyanosis, we talked about it, and we said cyanosis, the bluish skin or mucous membrane color due to deoxygenated hemoglobin. So when the patient is having a bluish color in the mucous membranes in the skin, then we just know that the patient is cyanosed due to decreased supply of oxygen in those extremities. Then diaphoresis, diaphoresis is excessive perspiration or sweating. When the patient is sweating too much, that term is called diaphoresis. So diaphoresis can happen in patients who have TB, whereby they sweat profusely during the night. So a patient can come to you and he tells you that I feel hot and I sweat too much in the night. Query tuberculosis. So cardiovascular terms, we talk about the diastolic, which is the volume of blood pumped out by each ventricle per minute. Then systolic, and documenting is very key because we need to report the pressures. We have to report the deviations of the different vitals so that we can be able to intervene. So the diastolic pressure is the lowest arterial pressure that is present during the diastole. And then the arrhythmias, this one deviation in the heart's regular kind of rhythm. So when there is a deviation in the rhythm of the heart, those ones we call them arrhythmias. And then the dysrhythmias is an irregular rhythm, further described as regularly irregular and irregularly irregular. So sometimes you can get the patient has irregular heart rates, and that one is called arrhythmias. But when you look at the dysarrhythmias, that one is actually in both sides, whereby you talk about the irregularities and then also the regularities of the heart. So the deviation from the normal heart rate, the way the heart functions, are the ones that we call the arrhythmias. The heart can either beat very fast or it beats very slowly, or gets an interval of having high rates and then again it lowers. So those ones are called arrhythmias. Then when you talk about the pulse deficit, this is when the apical and then the peripheral pulse differ, indicating that there is a potential cardiac issue with your patient, and we need to intervene in relation to that. So we want to look at the abbreviations in the vital signs charting. So when you take your vitals, you are supposed to know how to chart them. And in most cases, people do not put the real words. People can use abbreviations. For the case of temperature, they use T. So when they put it T, 30 degrees centigrade or Celsius, that one means temperature. Then also they can use the C, and that one can mean the Celsius, and then F can mean the Fahrenheit, and P is the pulse. BPM is the beats per minute, and R is respirations, SpO2 is oxygen saturations, and the rest as you see them. So, and in most cases, people do not actually consider to write all the words, but they can only use the abbreviations to mean what they mean in relation to vital sign assessments. So medication classes and vital signs effects. Remember I talked about some medications affecting our vital signs. So when you get a patient and you're taking some of these drugs, they can also affect the vital signs in relation to the blood pressures and also in relation to the saturations. Those are the oxygen saturations. So the opioid analgesics are one of them. Those classes can affect, and then also the cardiac glycosides. Those ones can affect the heart rate and the pulse. Then the beta adrenergic blockers can also affect the heart rate. And then we talk about the antihypertensives, as I mentioned them several times, can affect the heart and can affect the blood pressures also at the same time. And antipyretics can also affect the temperatures. So that is the end of our session today. I want to say that we can have our reference, and this is Wilson and then Susan F. and Jean Follett. We can get these books and read them. They can give us further explanations in relation to health assessment. So when you're looking at health assessment, you're supposed to actually put into consideration the vital signs as being the key thing that we need to know that can help us in the management of our clients. So thank you very much, and I want to say that this is the end of our session today. Let's meet again next time.